So I think we are ready to go. So I think this should be a really interesting session. We have presentations from three very different organizations who will share their experiences using community health workers or sometimes called family partners in different roles. And I think the roles are different. The organizations that they're embedded in, or the structures and contexts they're embedded in, are quite different. And I think the sort of cross-fertilization of thinking and ideas should be, very interesting. So our three presenters will present about their programs and the initiatives. Then we'll have time for discussion about some of the similarities and differences and what we can learn from the different experiences. So our first presenter will be Larisa Mendez-Penate, who I have known for quite a long time from Massachusetts Department of Public Health. And she'll be talking about her experience leading a variety of early childhood initiatives, most particularly My Child and Launch. But hopefully she'll talk a little bit about their newest initiative, which is called TMPEC. We will follow with Linda Cabral, who will speak about the experience from a different state, which I think is also really interesting, community care. I always get the initials mixed up. Who's from Community Care Collaboration of Rhode Island. That's not right. That's community. It's CTC, which is Care Transformation Collaborative of Rhode Island, and they are. Right now, they've had several initiatives to integrate community health workers into their practices. And we will finish with Practice of the Future, which is kind of a model pediatric practice within BMC that has been developed using human-centered design. And I think folks from that program can tell us more about their program and how community health workers are used there. So we will start with Larisa, and go ahead. Okay.
All right, so I'm gonna try to hold myself to 15 minutes here, doing the math. Okay, so just move the slide. I push this button. Doesn't seem to want to advance.
Does it should just move? Okay, it's not moving.
Thank you for confirming it's not me. Okay, so what should I do?
Just
Clicked that. And did you click here? Is that what you did?
Oh, yeah.
Right.
Okay. All right. We got it. Hi, everyone. There's a lot of stuff on this podium. So my name is Larisa Mendez-Penate. I work at the Massachusetts Department of Public Health, as Emily said. And my goals today are to share with you our experience at the Department of Public Health with community health workers, specifically community health workers who are working to integrate early childhood mental health into pediatric primary care. And to share the learnings from what we call the Launch My Child model, which includes very centrally the role of a family partner who's a community health worker who uses their lived experience navigating services for their family to support other families. And then I want to describe how lessons are carried into some other projects that we have going on. And we'll, as I see some of my friends in the audience, we will touch on early childhood MCPAP, but in particular mention the Transforming Pediatrics for Early Childhood project that Emily mentioned. So it's nice to be here with all of you, and I'm excited to hear from the other models as well. And before we get started, I just want to ask, just think back when you were a kid. Can you remember, do you have memories, either good or bad, from going to see the pediatrician? Do you have those memories? Yeah, I do. And then think about how many folks here have experiences, either good or bad, bringing their own child or a child who they care for to the pediatrician. Yeah, see, just a few hands. I was surprised it wouldn't be more. And then how many folks, I think, because I was just in the really great panel with hearing from a lot of family partners. Do we have any family partners in the room right now? Yay, I see a couple, awesome. How many people have the experience of going to a health center or going to primary care and receiving services from a family partner? Not yet. So that's something I'd like to see change. And then the final question is, how many folks have a child in their life, a child who they care about, who's a young child, whose behavior or social emotional development you have some concerns about? I'm surprised that's actually not more hands. So that was kind of what I also wanted to point out, is how common it is for young children to have something going on that a parent might be concerned about. So with that, let me just start off with a little base to make sure we're all on the same page about how we in the project launch My Child model have defined, or have the definition that we use for early childhood mental health. Infant and early childhood mental health is the developing capacity of a child from birth to 5 years old. Oh yeah, I'm gonna try to get it. Oh, okay. The developing capacity of a child from birth to 5 years old to form close and secure adult and peer relationships, to experience, manage, and express a full range of emotions, to explore the environment and learn. And all of those things happen within the context of the family, the community, and the culture that we're in. So that's 0 to 3's definition. So really what we're saying is infant and early childhood mental health is healthy social emotional development. Oh, good. It looks better up there than it does on my screen. So this is, we have someone in my office who does communications, so she made this. I didn't make all these nice slides. But this is a timeline. It's just a little taste. It's really focused from our state Department of Public Health perspective on the history of early childhood mental health integration efforts in Massachusetts. So it's not comprehensive of all efforts. But given the panel that we heard this morning, it's important to point out that way back in 2002, there was already a governor's commission on children's mental health, moving up to the Mass Child Psychiatry Access Project coming to be, and services starting in around 2005. Is that right? Did we put it in the right place, John?
Officially, end of 2000.
Okay, all right, so we got to move it a little. And then finally, the boxes that have the blue circles around them are more the grants that we're going to talk about today. So in 2009, we were awarded from SAMHSA the project launch and the My Child grants. They were awarded to the Department of Public Health and to the Executive Office of Health and Human Services. And we partnered with the Boston Public Health Commission to pilot a model at 77 community health centers in Boston. And so we started not having a model developed yet. So we went in working with those sites to develop the model of behavioral health integration in primary care. And the project launch grant was intended to be more focused on promotion. And the My Child grant was intended to be more focused on intervention and, really children who already had a diagnosis or at risk of diagnosis for an emotional disorder. In reality, with very young children, we saw that continuum was very, it was permeable, maybe. It was very hard to make a distinction there. Everyone needed all the promotion and intervention all at the same time. And another thing I'll just say about this timeline is in the context of other models that were going on at the time, Healthy Steps was already in Massachusetts at that time. And Project Launch and My Child built on learnings from that as well. Okay. So we had those grants, we piloted them. And then in around 2014, we were awarded expansion grants to replicate the model that we had developed. We took that to across the state to the communities of Still Boston, Worcester, and Springfield, and we're in 6 community health centers. Somewhere around then, maybe Team Up was starting to get going too. I don't remember the year of that. Yeah, so we should have put that up there too. Those grants continued. We were able to replicate them and showed additional good results. But sadly, we were not able to sustain those grants after the end of 10 years, which was really hard and sad, and went to some of the financing issues that folks talked about on the panel this morning. At the same time, we know that, as I've been describing, these models build on each other. Our learnings were growing into other learnings that Team Up was starting to be able to take advantage of. And in fact, I know for many of the health centers that were launched in My Child sites, it was a great relief that Team Up was able to come in and continue to allow them to provide those services. So I'll just mention here that now, getting up to closer to the present, that we now at DPH also have a grant from HRSA, which provides funding to build capacity for what we call MCPAP for early childhood. So the Mass Child Psychiatry Access Project. That's the grant that's listed as the Pediatric Mental Health Care Access Grant. So this allows for consultation to pretty much all primary care providers across the state, teleconsultation. So that's an immediate place where we're integrating early childhood mental health into primary care all across the state. Ideally, folks also have staff on site who are providing that support, but those two can work in tandem. And then finally, the grant, which I'll talk a little more about later on in the presentation, is Transforming Massachusetts Pediatrics for Early Childhood, which it doesn't roll off the tongue like Team Up, but it's TMPEC. And I will say more about that later and how Team Up is involved in that. So I just want to go back to make sure that it's clear that everything that DPH has been doing has been in partnership with a lot of folks. In particular, working with the Executive Office of Health and Human Services, with the Boston Public Health Commission, and then of course, all of the health center sites that have been involved in the work. So we developed what we call the Partnership for Early Childhood Mental Health, and we do have a website at ecmhmatters.org. And the vision for that partnership is that we are working toward a reality that allows all children and families to have equitable access to high quality early childhood mental health promotion, prevention, and treatment services in the context of family-centered, trauma-informed, and racially just systems. So that is all I need to say about that. I have a lot of slides, but I'm trying to go pretty fast. I'm not doing great. So on the timing, I mean, so just our vision, our ask for pediatric primary care. This slide depicts the partnership's vision of what we would like to see the pediatric medical home offer to families. So we want it to, really have a holistic view of the child and their family, have family-centered, family-driven services, opportunities for family leadership. And we really want that continuum of services to the level of needs of the promotion, prevention, and intervention. As much as possible, we want to have the services be available right in pediatric primary care. So staff who are embedded in primary care, and in the Launch My Child model, those were the team of the family partner and the early childhood mental health clinician who were included in the whole care team. Here's a little more about the model. Brings together primary care and behavioral health. We were able to fund, we didn't have enormous amounts of funds from SAMHSA, so we funded the family partner and the early childhood mental health clinician who were embedded in the practice. And it was really important to have a physician champion who was able to champion the addition of these new staff to the practice. For many of the practices we were working with, this was really new at the time. Today, maybe this doesn't seem as new. Finally, we needed administrative support to think about the operations and finance of the model. And the team participated together in learning sessions to support program development and quality improvement. I'll go really fast through the phases of service delivery. This is not that different probably from what a lot of your programs might do. But I guess I'll just, I'll highlight that in the referral process in Launching My Child, that warm handoff that everyone talks about often went to first to the family partner. But that's not required. If the family partner wasn't available, the clinician was, fine. If they both happen to be available at the same time, that could be great too, to meet them in a team. For the next step, where the family would get engaged and there would be some assessment, that can happen over more than one encounter, as works for the family. And also noting that even as you're doing that assessment, you're also maybe finding some small wins that you can, some small needs that you can support right away to engage the family. And again, this can be the family partner working with the family, can be the clinician, and really beautifully, when it's possible, the dyad. So the family partner and the clinician together as a team, providing support to the dyad of the child and the caregiver. And then for the goals development, this is where the team is really working together, and the family is part of that team in developing, and they're the leaders in that team in developing what their service goals are. And there's a listing of the folks who can be involved. It might be a childcare provider. It may or may not be the pediatrician. And the service happens where the family prefers it to be. So we did have occasional, not all the time, but we did have our teams providing home visits or visits in other places in the community. And getting to the sort of end of the service, once families achieve their goals, their needs would be reassessed. In Project Launch My Child, families would move out of an active service phase, but that didn't mean they were no longer part of the Launch My Child family, so to speak, because they were in the practice. If a need arose, the family knew where to find them. For us, the caseload, we were able, because we had limited funding, we were able to serve a relatively low caseload as well. I know this other models think about this differently in order to maximize caseload, but having that opportunity to return and know that there's a team there for you can also be really powerful for families. So in terms of results, we were lucky to have an evaluation provided to us by the Northeastern Institute for Health, Equity, and Social Justice Research. And I'll just very quickly say we saw a reduction in symptoms of parental depression and in parental stress, and reduction in symptoms of child social emotional risk. And just because I am taking more time than I'm supposed to, I'm going to skip a few things. I'm actually going to skip this slide entirely. I don't think there's much I need to say about it, but it's not letting me, oh, it's because these things all have to, there we go. Okay. So the heart of the model for us really is what we like to call the early childhood power couple that works together to support providers. And a key thing for us was that the clinician does not supervise the family partner, because they are peers who are working together, and they're able to model that for the rest of the staff, that the family partner is a critical voice in the care delivery. I'm skipping all kinds of things that you can read off of the slides. So importantly about the family partner, if we're launching My Child, it was someone who had their own experience of raising a child with behavioral health or other special health needs. The family partners has really been there. They can be very effective to bring the parent perspective front and center for the providers. And they're also a source of hope, showing that they've been able to overcome various challenges. It's important for family partners to have training on appropriate use of lived experience, and really to feel comfortable being able to set boundaries. Oh, did I not have the right slide up while I said all of that to you? Sorry about that. So you can read more of that at another time. These are just some quotes. I won't read them. I want to point out that we don't have a quote from a provider. And when I heard a provider talk earlier today, I thought we should have that quote, because we heard it, which was, now that I've worked with family partners, I don't want to go back to working without them. Okay, so Emily, what should I do here? Yeah. Okay, so maybe what I'll do actually is I'm going to just stop with the slides, and I'll just say, I think the strength is what I was trying to get across, was that piece about the family partner was the piece that we most want to see as part of a standard of care in primary care for young children. And so the piece that I'm not going to say as much about is we have a set of slides about our new grant, which is called Transforming Pediatrics for Early Childhood. This is a grant from HRSA. Eve, who is the director of that grant, is sitting back there, and she could speak to it better than me. And the exciting piece is that Team Up is a partner on that grant with us. And the reason is because we know that there are multiple people doing really great integration work in the state. And we want to use this grant to leverage all of that knowledge to advocate. I'm not supposed to say that as a state employee, but to advocate for funding of these kinds of services and leverage the 1115 waiver that folks were talking about this morning. And so we're really excited about that. We have a current cohort, which includes multiple Team Up sites, several Healthy Step sites, and we aim to fund a second cohort where we will have enough funding to actually fund that family partner role. And I think that is kind of what all the rest of the slides were gonna say. And let me just go to the back. Oh, I just want to say one last thing. I promise. Sorry. I want to give kudos to Eve because we also have several advisory groups who are supporting us in all this work. And one of the ones that Eve has just, together with other partners, has just brought together is a committee of 9 parents who are advising this new project. And they held their first meeting. And it was held with simultaneous translation. And we're just really excited about how that group will be able to influence how we do this future work. And with great apologies for not being able to stick to time at all.
Well, thanks, Larisa. So I think you present us kind of one model of thinking about family partners in a specific area. Linda, you are next, who's going to talk about really how an organization, a different sort of structure for fostering this kind of work, their context and the work they're doing.
Do you think I can pull up my slides here? The mouse? No. All right, great. So thank you for having me here today. Again, my name is Linda Cabral, and I'm from the Care Transformation Collaborative of Rhode Island. So your neighbor not too far down from the south. I have no disclosures to report. So I'm going to talk a little bit about our organization and the policy landscape in Rhode Island that has some similarities, but also some differences from Massachusetts that I think make it a supportive place for both integrated behavioral health efforts as well as community health workers. So I'll be talking about a couple of projects that do just both. So first, who is CTC? So we're mostly known by CTC. We have a complicated name, but we're a fairly new organization. We were convened in 2008 by our Medicaid office and our Office of the Health Insurance Commissioner. So Rhode Island is the only state in the country that has an Office of the Health Insurance Commissioner that regulates our commercial marketplace. And so they have some leverage over the commercial payers in the state. And so we help to support a lot of primary care transformation efforts. That's really the space that we're focused in, is in supporting and strengthening primary care. So we were established as a nonprofit in 2015 to do just that. So this is our vision, mission, and approach. So our vision is that all Rhode Islanders enjoy excellent health and quality of life. And we believe this can be achieved through a fully integrated primary care system. And we do this by bringing together a multidisciplinary approach. I think everything we do, and part of the power of our convening table, is that we are able to bring together different stakeholders, including state agencies, payers, as well as provider organizations. So some of the policy things in Rhode Island that make it supportive of both integrated behavioral health and community health workers is, as I mentioned earlier, we have this Office of the Health Insurance Commissioner that allows for some investments in commercial health plans to invest in primary care. And so in 2006, there was this legislation established to support this office to really enforce increases in primary care spend among commercial insurers. So we started in 2014 at a 6.3% rate of primary care spend among all spending among commercial payers. And we're just under 11% right now. So we hope to see that increase. And one of the ways that the Office of Health Insurance Commissioner is supporting these efforts is through investments in patient-centered medical home transformation. And so the Care Transformation Collaborative of Rhode Island had a role in helping to support various primary care practices in Rhode Island to get their NCQA PCMH medical home designation in order to strengthen primary care. I think Rhode Island is has one of the highest rates of PCMH adoption across the country. Most recently, some new standards that OHIC released just this past year is calling for increased investments specifically in pediatric behavioral health. And so we have a goal of increasing spending in community pediatric healthcare by 200% by January 2025. So that is a clear recognition of the crisis and the underinvestment in pediatric behavioral health in the state. And so I think some of the initiatives that we're talking about today really help to support those efforts. So Rhode Island is one of 29 states that has community health workers as a Medicaid reimbursable service. So this is something that I know Massachusetts is talking about. There's some interest in getting community health workers reimbursed. So again, this is just Medicaid. Our commercial plans are not covering CHW services at this point. We are trying for it though. So right now it's billable under a fee for service system, which has its challenges right now. CHW services are billed in 15-minute increments and a fee for service basis. I think there's a max of 15 units a day. There's a lot of, paperwork and cumbersome processes when you operate in a fee for service system, and a lot of conversation about how could we possibly get to a place where this is under a capitated alternative payment. So we're not quite there yet. This is a first step. And you can see there the rates. We've got a small rate increase over the last year. So this has just been underway for about a year. We're really in our infancy stage of having this as a Medicaid reimbursable service, and the uptake is still kind of slow. I think what you will hear from some of the providers that are doing this is that these rates do not adequately cover the cost of a community health worker. One of the things that I think is a positive is that community health workers can bill for collateral services. So if they're on the phone with a provider for a referral on behalf of a client, they can bill for that. The client doesn't have to be in front of them in order to be able to bill for services. So that collateral ability to bill for collateral services is really important, but it still does not cover the full cost of the staff member. And I will say that, like, for community-based organizations who employ community health workers who maybe don't have a lot of experience with billing, they are at a slight disadvantage over some of the medical providers who are employing community health workers who have experience with how to get your EMR set up to bill and know how to bill things, have a billing department for these smaller community-based organizations that are employing community health workers and trying to bill for it, they face those additional challenges. We have a very strong community health worker association in Rhode Island that does training, initial training for community health worker certification, as well as ongoing training for community health workers. And our largest employer of community health workers is called Ripen. They are our largest employer of community health workers, and they are a resource to providers and other smaller organizations who maybe don't feel comfortable in hiring a community health worker themselves because they don't know how to supervise, or this role is really new for them. And so they're able to kind of outsource to Ripen for community health work, and Ripen will do the hiring, the supervision, the support. And so that's kind of one of the unique roles that we have in Rhode Island. So CTC has done a lot of work in integrated behavioral health. We started with the adult practices, and in 2019, we started working with some pediatric practices. And so we've had 8 different pediatric practices go through 2 different cohorts where they receive support from our organization to really expand their integrated behavioral health capacity. And so we had a couple of outpatient clinics, 2 FQHCs, and 4 community-based primary care practices participated in this with funding support from our Rhode Island health plans, as well as our largest foundation in Rhode Island called the Rhode Island Foundation. Oops. So what this looked like is, with the funding available to these practices, they were able to hire a behavioral health clinician who could participate in that team-based care, working with clinical staff to participate in warm handoffs, participate in those huddles and pre-visit planning. And they also were able to benefit from some coaching or practice facilitation from experienced staff who could help with some of the workforce implementation, workflow implementation, as well as how to bill for services, really maximize revenue now that you have this behavioral health clinician on staff, and how to really maximize having this new staff person on board. For practices that weren't already screening for depression, anxiety, and substance use, they were now doing so among the pediatric population. And we had them participate in a quality improvement process with doing a PDSA. Oftentimes, this is around, increasing your screening and developing a registry. And these practices also participated in a learning collaborative where they're able to share with one another and meet regularly with one another for peer support and learning. So this is just one data point that I'll share with you regarding screening rates for depression, anxiety, and substance use among the pediatric practices. You can see increases from baseline over 10 quarters among, for depression, anxiety, and substance use. And so that was kind of as an organization, our baseline. Okay, we got some practices with an integrated behavioral health clinician. What can we do to take it to the next level? And that's where community health workers came on board. So we have 2 different initiatives that we're currently supporting, that is leveraging community health workers to expand the IBH care team. So the first one I'll talk about is DULCE, which stands for Developmental Understanding and Legal Collaboration for Everyone. And this really is focused on super early childhood support. So from birth to about 6 months. And it's geared toward addressing health inequities facing infants and families from low-resourced communities. And so in this case, the community health worker is called a family specialist, and they really work as part of a multidisciplinary team to be proactive about addressing clinical, social, and behavioral health needs that these families may be facing. And the multidisciplinary team, in addition to the providers, is also a legal specialist on the team to provide that perspective. And so the family specialist really serves as a partner to the family. They accompany them to all well child visits. They will meet with them in the office prior to the visit, just to debrief. What do you want to talk about today with the doctor? What concerns do you have? Making sure they know what questions they have going into, and really helping be an advocate for the family. They're doing the screening for the social needs and behavioral health needs, and then doing those linkages to community resources. When we can see here, this Dulce is something that's been implemented nationally. We're doing it with a couple of practices in Rhode Island, but the national evaluation around this project shows, not surprisingly, better outcomes for babies and families on various indicators. So now I'll talk about our recent collaboration with Team Up that allows us to bring some of what has been learned in Massachusetts to Rhode Island. So wanting to expand the capacity of our pediatric practices to expand their IBH capacity. So even though they had an IBH clinician, they still, are not able to see meet the demand that is facing them. And so we wanted to embed a community health worker as part of that team to expand the IBH capacity. And so we were able, with support from various health plans and the Hassenfeld Child Institute at Brown University, to contract with 6 different pediatric practices to embed a community health worker and receive specialized training from some of the staff here at Team Up. I think one of the biggest differences between the practices that we have in Rhode Island and the practices in Massachusetts is that yours are all FQHCs and none of our practices are FQHCs. They're all community private practice providers, and our patient panels are a lot smaller as well. But I think a lot of the clinical learnings and the models that you have done here in Massachusetts are certainly applicable to the work that we're doing, where we are providing clinical training to the community health worker, as well as the whole team, about how to work more collaboratively to make those warm handoffs work, how to do universal screening more effectively, and how to have those workflows in place to connect with specialty services. And so that project really is just in an infancy. We had our fundamental community health worker training happen last month. And so we're going to be supporting these practices for another year or two, depending on which track they're on. And so they're going to be receiving monthly practice facilitation, as well as the collaborative learning that many of our projects benefit from, that peer learning and support. So as far as what's next, we know that workforce shortages are impacting not only behavioral health clinicians, but community health workers. Positions remain empty for a long time, it seems, no matter what. And so we're trying to continually figure out how we can best support workforce development efforts on all fronts: primary care, behavioral health, and community health workers. And then how do we support a career path for community health workers, helping them either specialize in particular areas like diabetes or cardiovascular disease or behavioral health. We have those tracks within Rhode Island for specialized training. And then how can they, develop themselves both within and beyond the community health worker role. That's kind of where we're thinking when we look ahead. So thank you so much for having me here today. And it's been really great hearing more about the Team Up model, what's happening here in Massachusetts. So thank you.
Thanks, Linda. I think it's really interesting to hear about such a sort of different policy context. I think we will be very eager to learn how your reimbursement efforts go. And I'm also really interested in thinking about, how you engage the insurers and the other payers. And it's not something that, at least in Team Up, we have work to do, but clearly something very necessary. So our last speaker will be Mirka Joseph and Elizabeth Jimenez-Cog from Practice of the Future. So come on up and we look forward to your presentation. Is this mouse? Thank you.
Hi, good afternoon all. My name is Elizabeth Jimenez-Cog. I am with Boston Medical Pediatrics under Practice of the Future, or for short, POF, and I'm here with.
Hi, my name is Mirka Joseph. I'm also one of the community wellness advocate with POF at BMC.
What is Practice of the Future, or POF program? BMC Pediatrics launched the POF program in January 2020 to try new ways of delivering care to families with newborns based on what families have told us about their health care can better support them. In addition to standard pediatric care that all patients receive, our families are offered additional supports and services based on their priorities for their family's health. The POF program team includes 2 pediatricians, 2 community wellness advocates, a social worker, a practice coordinator, and a nurse. What is the POF program? Why was the POF program designed? Before creating the POF program, our team spent a year learning from families about their goals and priorities and their ideas about how BMC can best support them. We learned that there are things that families wanted their BMC teams to prioritize in regards to their health, and that there were specific things that pediatrics could do differently to better support them. Our work with families is guided by the understanding that the family's health is defined by their culture, their community, and other factors beyond BMC. They are the experts in setting goals and priorities for their family's well-being and should be in the driver's seat as we partner with them to design their care. Building on their family's strength is the best way to ensure their health over time. As mentioned earlier, the POF team has 2 pediatricians, Dr. Cindy Hatcher and Dr. Sarah Stulak. They provide primary care to pediatric patients and direct families to any other services they might need at BMC and beyond. The 2 community wellness advocate, myself and Merica, we connect families to any resources that are needed and plan for the patient's visit with the families and the care team. Our behavioral health social worker, Rachel Claiborne, supports with mental or behavioral health questions and concerns that family may have. We also have a financial coach, Barbara Alcina, who helps families make plans to reach financial goals. Our practice coordinator, Candace Pina, helps schedule appointments and connects families to other departments at BMC. We currently do not have a nurse, but once that role is filled, she will provide, or he will provide, health education and support and guide families with various medical needs. One thing that we like to do when we meet with new families who might join our POF team is we provide them with a one-pager that has our faces so that they can easily identify us in clinic, also our names, what we do, and ways to communicate with us, whether it's through email or through a phone call. What is included in the POF program? Frequent access to the care team in person or virtually. Planning ahead for well child visits so that we can coordinate the visit based on family needs and priorities. Coordination of BMC visits for the family. Financial economic supports, including a financial coach. Tailored wellness planning that sets out the goals and priorities for families. Support and connection to resources such as assistance with finding employment, going back to school, applying for funding and financial assistance, housing needs, and many more other assistance, connecting parents to adult primary care provider if desired, and collaboration between families, their BMC care team, and other providers.
So our program, we have many different model components. So those are services that we ensure that our family receives. So the first one is family mapping. So with family mapping, the clinical team, we meet with the families, and that's a way for us to learn about the connections that they have already within the community, their strength, their weaknesses, their linkage, and their potential needs. So once we have the family map, then it helps us understand where we can fill the gaps in terms of meeting the family needs. The other aspect is it's called goal setting. That is when one of our member, they meet with the family and they discuss what are the family goals. So they talk about short-term goals and long-term goals. And as a team, we come together to figure out how we can help the families accomplish those goals. It could be financially, it could be health related or social related. So we just try to make sure that we help them and assist them. And also we do frequent check-in to see how they're progressing and how we can help them during the process. We also do something called panel review. This is when the clinical team, we try to review the full panel. So whether the patients have appointment coming up or not, we make sure that we go over a full list to check if everybody is updated with their vaccines, with their appointments, if there are any medical needs that needs to be addressed, any social needs, behavioral, or mental health needs. So once that's done between the team, one of us will reach out to the families and we try to meet those needs for the families. The other components is the family wellness plan. So that is when we combine the goal setting and the panel review to make a plan basically with the family to know how we can better move forward. Those three components are the ones that we do the most, I would say on a weekly basis. The family, the pre-visit planning, visit prep, and family visit agenda. So during pre-visit planning, myself and Liz, we would call the family about a week before their appointments. We talk to the caregivers and we ask them if there is anything in particular they want the doctor to prioritize during the visit when they come with the child. That helps the families a lot because oftentimes when they come to the appointment, if they didn't have a conversation prior, they sometimes forget to address certain things. So having that conversation in advance, it really helps them a lot. So they talk about their medical needs, if there are anything that they need help with socially. For example, a lot of families, they need help with transportation, getting to the appointment. So we assist them with that to make sure that they can get to their appointments. If they have any food insecurity, so all of those needs, we try to address them during that conversation. So after we talk to them, we do something called visit prep. That is when the whole clinical team, we meet. We're currently doing that on Zoom. So we meet and then myself and Liz will discuss to the team what we talked about with the family, and the pediatrician will come up with a plan of what to address for the medical needs. Whatever that's needed to be addressed by myself or Liz, we do that on our end. We have a behavioral health social worker, if there is anything that needs to be addressed by her. So we all come together to come up with a plan so that that visit can be very productive for the families. And then we do something called the family visit agenda. So that's when we combine everything that we talked about with the family and with the clinical team to make sure that we go through this throughout the visit. So there are a couple findings from the program. We do have a research team and they do evaluations with the families. So nearly all parents report that their care team regularly reviews and updates their care plan. Their care plan includes all of the things that are important to them, and that they are encouraged to express honest opinions about POF, and that their care team reduces barriers to other services. Another point was that the majority of parents report that they believe that their care team feels comfortable around people who look and sound like them. The care team considers their values and tradition when recommending the treatments and services, and that they feel cared about the clinical team. And that's very important because in the medical system, it is not simply about providing treatments to the family or just throw it at them, but it's important to consider the values, the traditions, what is important to them, and also how we can both work together to make sure that the child's well-being is being taken care of. And also nearly all parents reported that the services they receive from POF help them to live a better life, that the staff truly believe in them and that they can reach their goals. They feel safe in POF and they trust our staff. And also it is important, the trust is built by having a connection with them. So we make sure that the families are not left behind. So we have a personal work number. They can text us, they can call us. Many times we try to call family, they have work, they have things going on, but they can easily leave us a text, or we can easily leave them a text or a voicemail. They know that there's somebody who's there available for them. And also at least 89% of parents reported that their care team considers other aspects of their life when helping making healthcare decisions. The POF staff help address urgent medically related social needs, and that the care team help coordinate services, and that the staff work together and coordinate care with other service providers. So lastly, the mission of the POF program is to ensure that all families have an equal opportunity to be well and to achieve their full potential. The POF program model was designed through a family-driven process of human-centered design to lift up the priorities and voices of families in our practice. So we really focus on providing that team care-based care to our patient, and also making sure that the families are the one driving their care. So we don't make decisions for them. We make sure that their voices are being heard. We make sure that whatever they want to prioritize is prioritized, and we try to meet their needs as much as we can. In doing so, we are working to build an equitable health system that fosters families' self-efficacy and autonomy and promotes social and racial justice. Thank you. That's all. Thank you.
That will be squeaking nonstop. So obviously I hear a lot of common themes across the three presenters with the integration and the including the CHW role within the various programs, particularly with medical care settings. So I think one of the questions that I had, and I'm not sure if the panelists would be able to answer this, especially with your presentation, Linda, with the billable service of community health workers in Rhode Island, just thinking about the, I guess, Massachusetts system, because there are some, I guess, particularly with the CBHI services where family partners are billable services, but it seems like the role are billable within the mental health realm and not necessarily within the medical health realm. So not quite sure if I guess the folks at DPH would be able to answer that. I guess to me, what feels like a mismatch with the community health worker roles seemingly being more appreciated within the mental health realm.
Thank you for that question, Mark. And I don't have a really good answer, but that is also my impression that it is easier in behavioral health that was built into the CBHI system, and that those family partners are able to receive reimbursement for their services. And I know that other people in that field to speak to that. I'm not Suzanne, but I will say that that is really what we model the family partner role in Launch My Child after. And we were not able to craft that within primary care, although we had a health center out of Springfield that partnered with a behavioral health agency, and that agency had the family partner model, so they were able to build because they were embedded in primary care, but they were actually employed by the mental health work. So that was the way that one sci-fi around that, but that doesn't seem ideal for what we're talking about. And I know people are looking behind Suzanne.
Just. Number's been around for a while. Reason for that was a lawsuit over the years. And the state was very concerned that they family partners were required as a remedy for the lawsuit. And I believe they were very concerned there wouldn't be enough folks to meet the needs of the lawsuit as well if they expanded into primary care right away. But as Suzanne says, now we have the opportunity, hopefully. And a few places like in Springfield figured that out, that if they got the CSAs that had the family partners to come into the physical side, it did, the billing did seem to go through, but it wasn't the way it was designed.
And I was just going to add, I'm in a dual role. So I'm in Rhode Island as part of CTC, and I'm also at BMC. So when the billing codes for CHWs went into effect, everyone was initially really excited. And what you found is that, if someone was billing for every 15 minutes of their time, except for lunch, so this is like 8 hours a day, every 15 minutes, which again, now that you think back, you think, how would that be reasonable? But that would get close to the salary. But in reality, that's not what is happening, right? And there's still a lot of work that we all do, but in particular CHWs, where it's not a billable code in this way that it's set up. So if I could say what the preference would be, I would also say that the PMPM, which I'm now on the BMC side in Pop Health, if you're a tier 2 or tier 3 site, there is additional funding available. And if you're a pediatric site, I believe there's even more funding than if you're just an adult site, regardless of your level of complexity or risk. So I think it'll be interesting to see, but the idea of having to keep track of everything you're doing for every 15 minutes and then billing that is just very cumbersome. And again, would not get you to an ROI unless you billed every minute of your 8-hour day.
So I don't have the details really, but I know it is grant funded. Yeah.
I wanted to raise a question which often comes up and I think is reflected in the diversity of these programs, is when you're thinking about the family partner CHW role, how do you think about the criteria or the component of an individual's lived experience? I know for Launch and My Child, that was really central. I know for at least in terms of the CHWs who were hired in Rhode Island, that was not specific criteria. So I'm curious how you all think about that, both from perspective of both program management, program design, from being in part of a program, being service providers, and then from the state in terms of also program design. Anybody want to take that one?
So for the work that we're doing in Rhode Island, I think, and I'm not sure how it is in Massachusetts, but we have a pretty robust community health worker training program that covers lots of different disciplines, from behavioral health to diabetes to elders to cardiovascular disease. And so one of the requirements that we have is that any community health worker that is funded in our programs has that certification or has planned to be in 6 months. So there's a path for that. And so that's kind of step one. And then kind of step two is really relying on the practice team and hopefully ensuring that whoever they are seeking to hire in their recruitment process is a good fit. Obviously, that lived experience is really critical to establishing trusting relationships with the patients that they will likely be serving. But also fit within like the practice team is also something that has to be factored into. So those are, I think, two of the things that we like to encourage our practices to be thinking about.
So for us, I think the criteria is mostly having that experience with community and also making sure that the workers are actually connected to the community, because we do a lot of work with resources and making sure that the families are connected. So having somebody who have that experience, who's also able to connect with the families, you know, not just on a medical level, but also on a personal level, because that is very important for families. So having people who look like them, people who speak their languages. At BMC, we do have a very diverse population. So myself and Liz, we do speak different languages, and that is one thing that does make a big difference for our families. So I would say those are some of the criteria.
So for Project Launch and My Child, as Emily said, the family partner and someone who really received training to use about how they use their lived experience was really critical. I agree with what the other panelists are saying. I worked at a community health center, and when I actually interviewed for the job to be the launch coordinator, I was told about the family partner role, and I said, "Oh, you know, we have those folks at our health center," and they were like, "No, that's community health workers," and that's right. They have lived experience often, and they can use that in their work. And I would argue that a pediatrician has lived experience that they are able to share with a family as well. And in fact, we've seen family partners be able to help pediatricians be able to bring a little bit more of themselves into the work that they do with families. So for the early childhood mental health piece, we felt that experience of having navigated that particular challenge was really important for families who are just learning that their young child may have a diagnosis, to be able to sit with someone who can say, "I've been through this." It was just really powerful. So that's how we modeled it. And I think that all the different kinds of community health workers and different levels of lived experience that people can provide are really valuable.
Do I correctly understand that much of your practice is within the private practice? Yes? Okay.
Yes.
Okay.
Most of the care provided specifically to children, specifically to children in Rhode Island, is done in community private practices.
Okay, great.
Our FQHC landscape is not as robust as in Massachusetts.
Yeah. Well, I think there's a strength in that. I'll tell you what I mean, because now you're beginning to think ahead as to how do you finance, how do you support financing of CHWs in the long term, right? So my question would be, what's your 1 year, 2 years after this funding that's available now is exhausted? What are the thoughts you have as to, with regards to sustaining and expanding the services of CHWs within the system?
Yeah, so clearly, we see community health workers as sustainable through a multi-payer approach. And I think, you know, when we hear national experts talking about community health workers in other states, what they've said is that no one state has been successful in having community health workers sustained just through Medicaid alone. It's not a single pathway. You need to have Medicaid as part of your sustainability plan. And so you're always gonna have to be relying on some like grant funding or some, but you know, what I would like to advocate for is looking at alternative payment methodologies like a PMPM. In primary care, like we can make it work when practices have some flexibility within their resources. And so you have a really strong ACO marketplace here in Massachusetts and Rhode Island. We have our version called accountable entities. We're not quite there yet with you, where you are with your alternative payments, but we hope to get there. And so a lot of our pediatrics are also provided within like general family medicine or internal medicine practices. And so there you have the whole lifespan of patients being served. And community health workers obviously can be really helpful for adults as well. And so I think billing is one part of the solution, and what our practice facilitators are doing with the projects that they are supporting is helping practices get ready to be billing if they're not already doing so. Like, here's what you have to do, here's how to set it up, here's how you have to register as a provider, here's what you can bill for, here's what you can't bill for, here's how to maximize everything. So as I said, one component of a much complex solution.
I'm just going to make a comment on the dilemma we face with right now with the per member per month. I think we are all trying to be very hopeful that that will lead to more opportunities to integrate CHWs across practices, and particularly in terms of pediatric mental health. But we're also realize that each site has a lot of flexibility on what happens with that extra money and where does it flow. And there's no guarantee that it will be used for pediatrics. It will be no guarantee it'll be used for mental health. And the tiers help, but many of the sites already are able to meet those tier requirements and still they meet them, but they don't have a path towards sustaining the CHW role. So, I think Linda, one thing you said that I think is really important is that we have to think of a multi-payer strategy. We need to think about who else can contribute to the infrastructure, to training the teams and supporting the CHWs in their role. And I hope that happens.
One more thing, and when I say multi-payer, I mean not just Medicaid too. Because right now it's only Medicaid that's covering CHW services. So when you think about a pediatric practice, again, in Rhode Island, they're not FQHCs by and large. They're regular private practice who are serving sometimes maybe more commercial than Medicaid. And so how can they plan a system that, some of their panel gets covered by this and something, it just complicates things more so. And so that's what we're trying to advocate for, is coverage of community health worker services across all payers.
I think we are at time, is that correct? Okay, so on behalf of Arth and myself, we would really like to thank all our panelists, like to thank our audience. I think we learned a ton about different ways that community health workers have been used. They all have different names, but I think they share the same kind of commitment, and hope will inspire us all to think back about different ways that community health workers can improve the care that we give to kids and families.